Hello and welcome to another episode of the Young Tongues podcast. My name is Barbara Fountain and I am the founder and CEO of the Young Tongues, a peer-to-peer support group for young tongue cancer patients. And welcome to another episode, the second one of this season, and I'm absolutely thrilled. Joining me today is an expert guest, more specifically Professor Kevin Harrington, who is a consultant clinical oncologist at the Royal Marsden and Professor of Biological Cancer Therapies at the Institute of Cancer Research. He specialises in head and neck cancers and is internationally recognised for his work in developing innovative treatments including immunotherapy and gene-based therapies. Alongside his clinical work, he plays a leading role in research aimed at improving outcomes and quality of life for patients. Kevin, welcome to our lovely little podcast. It's lovely to have you.
Well, it's a great pleasure to be here, Barbara. So thanks, and also thanks for that kind introduction.
You're more than welcome. We're really thrilled to have you. We've had many requests from the community asking if you could join us on the podcast. So, just for people who don't know you, can you tell us a little about your journey into head and neck cancer and what drew you to this field?
Yeah, it's going back a long way, I'm afraid, Barbara, because I'm quite old now. But I trained I trained in medicine in London at St Bartholomew's Hospital. And I knew from an early age that I probably wanted to be somebody who looked after patients with cancers. And during my junior doctor training, I was lucky enough to be appointed as what was called a senior house officer in those days at the Hammersmith Hospital, where I worked with a number of specialists, including Professor Carol Sikora, and he really enthused me with the idea of training as an oncologist. And so I came back and I did exactly that. I was always interested in training in both radiation oncology and also in drug treatment, so with chemotherapy. And so I took a career in clinical oncology, as it's called. It's a rather unique form of oncology training in the UK and I guess English-speaking countries, where you're trained to be an expert both in radiation delivery but also delivering chemotherapy, so almost like a radiation oncologist and medical oncologist. Now, during my training, I was lucky enough to work with somebody called Dr. Simon Stewart, who was just a fantastically enthusiastic oncologist and worked in head and neck cancer. And so when the time came for me to decide what I was specialised in and what I would do my PhD research in, I had the chance to work in head and neck cancer. And in many ways, once you start down a road and you begin to make some discoveries, quite often you just find that one thing leads to the next. And I found exactly that. And so I've never really deviated from the path of wanting to look after patients with head and neck cancer. I found it fantastically interesting, fantastically rewarding. Um, the disease has changed a bit since I first started training. It was most commonly a disease of middle-aged and elderly men, mostly elderly men, related to smoking and drinking. And certainly I remember during my training you'd meet some fairly colourful characters in the head and neck clinic. And I think in many ways that was one of the things that drew me into it. It was not just interesting, but it was also fun to do the clinics. You'd meet some interesting people. And it's always continued that way. The demographic has changed a little bit, but my enthusiasm for the discipline has never wavered.
Amazing. Thank you so much. Now, as you know, says in the name, Young Tongues. We very
Yes.
much focus on the cavity tongue cancer element of head and neck cancer. And one of the things I wondered is, as you've had such a long career, how do you think, what has changed about tongue cancer? You've mentioned earlier that the patient population is slightly different, but what is the most change that you have seen over the last couple of decades?
Well, there's no question that the biggest change doesn't relate to tongue cancer or oral cavity cancer at all. The biggest change has been the emergence of this, or the recognition of this diagnosis of HPV-related oropharyngeal carcinoma. And I suspect you and your listeners have heard about this on more than one occasion before. But up until about 15 years ago, we didn't really recognize that there was such a diagnosis um, lurking, really. unseen within our practices. And of course, we now see that within our practice, at least 60 to 70% of new cancer diagnoses occur in the oropharynx, and that's the bit of the back of the tongue behind the oral tongue, so the posterior third, the back third of the tongue, the tonsils, the palate, and the pharyngeal wall at the back. That's where these tumours arise, predominantly in the tonsil and in the back of the tongue. And it's related to virus infection. It's not related to cigarette smoking or drinking alcohol. And that has really led to a change in how we think about um, diagnosing and treating head and neck cancers commonly in the clinic, because we have to take account of this HPV positivity. But in addition, I think there is a growing appreciation, and I suspect the clue is in the name of your organisation, that there has been, I think, a greater appreciation that we are seeing more younger people developing cancers in their oral cavity, particularly on the tongue, for instance, but also in the floor of mouth, but mainly in the tongue. And nobody can really explain that. It's not related to exposure to things like tobacco and alcohol in the main. It's not related to genetic abnormalities as far as we can tell, although we always search for conditions like Fanconi anemia or dyskeratosis congenita, which can be associated with oral tongue cancers and oral cavity disease. And we don't really understand that. And I think that that is something else that is nagging away at us, as to we sort of understand what's going on with HPV positive disease, but we don't really understand this. It's not an epidemic, it's not that common, but we are seeing increased numbers of younger people with these tumours that really we shouldn't be seeing before the ages of 50, 60, 70, that sort of thing.
Yeah. Definitely what we see within our community. And you actually partially answered one of the questions that Chloe from within our community asked. So she asked, where is the evidence at in terms of why younger people are developing tongue cancer without clear risk factors? And as you mentioned, we don't really know. But the second part to her question was, what do we currently understand about the risk of future cancers to this group, which is something we're seeing more and more because we're quite young. Yeah. Only because we've had tongue cancer doesn't mean that we don't develop another type of cancer, or indeed a recurrence within the cavity tongue cancer as well, and not necessarily within the first couple of years when you would expect to see a recurrence, but quite often many years after. So I guess the question is are you seeing that in clinic as well, or is it too rare to see on a day-to-day basis?
Yeah, it's difficult for any individual clinician, I think, to have a fully rounded view of this, because um, although we have, I think anyone who works as a head and neck oncologist will have met people in their late teens, early 20s, who present with cancers in the oral cavity, principally in the tongue, sometimes in the cheek. And of course, those people stay with you, and they stay with you in your memory. Now, hopefully, they also stay with you because you follow them up. And I'm pleased to say that I do have patients who we've treated and who are, I hesitate to say the word because I'm a bit superstitious, but cured of their disease, because it's many years now since they were treated. And so we do, and we remember those patients. Now, in terms of the risk of another malignancy, now there is the ever-present risk of recurrence. Now, we just need to be clear what we mean by recurrence. So there are lots of definitions of recurrence, but essentially a recurrence of a disease should occur within a defined distance of the original primary tumor. Now that definition varies, anything from 1 centimeter to as far as 3 centimeters away from the primary tumor. People have used those definitions. So it should be something that's arisen in the same place as where the original disease was, so that you can genuinely call it recurrence. And then there's the time factor. And again, people variously think about the time in terms of it should occur within 2-3 years. Some people would set the threshold as 5 years, and maybe that's a little too long. Now, disease that occurs 6, 7, 8 years after the index diagnosis, that's probably a de novo, a new primary tumor. Now, of course, that then gets to the question, are people who develop one of these tongue cancers, are they simply, they've had their piece of bad luck, they've manifested the tumor for reasons that we don't understand, and if the disease is controlled and cured, hopefully they won't have any further problem. Now, um, that is possible, but of course there is the risk that patients could be at increased risk of developing another one because there's some unknown factor that predisposes them. And that's something that we're trying very hard to understand. We don't have a good handle on that yet.
Mm.
We're analyzing the genetics of the individual tumors that arise and trying to see, is there a pattern there? Is there a clue? The other thing that I think you alluded to in the question is, of course, regrettably, for people who present at a young age with a type of cancer such as a tongue cancer, the treatment often involves a surgical procedure and then, as you and your listeners know, radiation therapy and often also chemotherapy. Now, they in themselves cause mutations. Now, they are absolutely essential in many situations for curing the disease, but you store up some problems for the future
Mm.
potentially. So essentially, there is a risk of having a treatment-induced later relapse of the disease, or indeed um, better described as a new primary caused by the treatment that you've given with the best of intentions of curing the original disease. And so we're trying to understand that whole phenomenon of, is it a genetic predisposition and you see multiple tumors? Is it a condition whereby the treatment itself has caused the problem? Now, in older patients where we see particularly with carcinogen related tumors. So these will include smoking and drinking and the use of smokeless tobacco, pan, betel nut chewing, for instance, especially in Asian communities, but by no means restricted to Asian communities. We know that what we see is we see what's called a field change within the lining of the mouth. And that means that essentially quite a lot of the cells within the oral cavity and in the tongue itself, for instance, may have undergone some pre-malignant event as a result of the exposure to those um, uh, precipitating factors. And of course, that then means that new lesions can be popping up all the time. And we do see patients who come back with again and again dysplastic lesions or frankly malignant lesions who have multiple episodes of this. Now that is usually in the group of patients who have had been exposed to some
Mm.
carcinogenic substances.
Amazing, thank you so much. Now, as you've hinted at, you've been involved, heavily involved in research, um, different types of research, but I think I've come across you mainly because of your research on immunotherapy.
Yeah.
Could you talk us through what this work entailed and what you've seen change through the work that you've done?
Yeah, I mean it's changed dramatically, Barbara. I'm pleased to say, and and sometimes it's only when you look back at a great distance that you can see how far you've come, if you
Mhm.
understand what I mean. So, when I started training in head and neck oncology, I remember, and I guess I'll tell an anecdote which illustrates the point. So, I finished up my training at the Royal Marsden Hospital, working for the senior consultant in head and neck oncology there, a great radiation oncologist called Michael Henk. Now, there was a patient who would come back to the clinic, and he'd come back every 6 months, and he was a man who had presented with recurrent head and neck cancer and had received chemotherapy, and his disease had gone away. Now, nobody could believe it. People had looked at the pathology, they double, triple, quadruple checked it really was recurrent cancer. And this man was alive something like 4 or 5 years after this diagnosis of recurrent cancer. And he would gladly come back to the clinic so that each new batch of registrars could meet him and see that it was possible to cure head and neck cancer when it had recurred in this way, because it didn't happen. So
Mm.
the 2 year survival rate for patients with recurrent head and neck cancer that was not operable in the time when I was training, and I'm talking about the early 1990s, for instance, the 2 year survival rate approximated 0%. Almost nobody lived beyond 12 months, 15, 18 months. And so this gentleman was seen as a great success. Now, we're now in an era where we're using immunotherapy, and we're at a point with immunotherapy where we're publishing and we're reporting on 5-year survival rates, 5-year survival rates in excess of 20% now. Now, that's not good enough. It's not as if we should pat ourselves on the back and say we're done here, but it shows the distance that we've come and the improvements that we've made. And so we have slowly been able to demonstrate in patients with recurrent and or metastatic head and neck cancer that if we use treatments that target their own immune system rather than trying to poison the tumor to death with chemotherapy drugs as the only treatment we use, that actually we can on occasions put people into maintained remissions, and those maintained remissions really look as if they can turn into cures. And that's really, I think, the most exciting thing that's happened during my clinical career in being able to turn a disease that was really anecdotally, occasionally, once in a blue moon, you'd have a patient who would live a long time, to now we can reliably predict that we may well be able to cure 1 in 5 patients with this disease, or have a durable remission up to 5 years, 1 in 5 patients. And of course, that gives us the starting point for the next wave of advances, I hope.
So hopefully many of our listeners won't ever have had the conversation about having immunotherapy,
Yeah.
because they will have had surgery, maybe radiation, chemo the
Yeah.
first time round. So for them, or for us, I should say, me included, what is immunotherapy and how does it work?
Yeah, it's a great question to which there's not a very easy answer, but I'll try my best. And usually, if I'm seeing somebody in the clinic, I've got a piece of paper and I draw pictures. I'm a great drawer of pictures for patients. I think it helps to illustrate, but I'll try to paint the picture in words. So immunotherapy is a complete change from the way we've addressed treating cancer for the last 100 years or more. And the reason why it's a complete change is that the object of the therapy, the target of the therapy, is not the cancer cell at all. So up until now, operations have been designed to remove the cancer. And the thought process of the treating surgeon was all about the cancer itself. Radiation oncologists and medical oncologists who give chemotherapy drugs have been using treatments directly targeting to the cancer, hoping to kill cancer cells. So we use noxious, unpleasant things targeting the cancer to try to kill them. Now, in contrast with immunotherapy, what we try to do is we try to open a dialogue with the immune system. So the underlying hypothesis here is that every single patient who comes to the clinic who has a cancer in their body which is clinically visible to themselves, to the doctors on scans, for instance, that cancer must have learned during its evolution to escape from the immune system. And so during the genesis, during the formation of that cancer, there is a hypothesis called the 3 E's hypothesis, where our immune system, first of all, if there's the beginnings of a cancer, may be able to eliminate it. And of course, we suspect that all of us may be prey to cancers that are maybe on the point of occurring, and then our immune system snuffs them out. That seems to occur. So that's the elimination phase of the E. The second phase is the equilibrium. Now, for some of those lesions, the tumor cells themselves begin to have a dialogue with the immune system, and they can keep the immune system at arm's length, but the immune system is still powerful enough to suppress the cancer, so it never grows beyond a certain size and may never even become visible. And that is the equilibrium phase, where there's a sort of an uneasy truce between the cancer and the immune system. If the cancer gets too big for its boots, the immune system will attack a little bit more. But if the tumor doesn't get too big, maybe the immune system will be unable to snuff it out completely. And then there's the third phase, which is every patient I meet in the clinic who is in the escape phase, whereby their immune system is now no longer able adequately to see the cancer. And that's because that cancer, and we hypothesize, during that equilibrium phase, the tumor cells are still growing. Some of them get killed, but some of them survive. And those cells are evolving and they're changing. And every now and again, a change occurs that gives that cell an advantage that makes it a little bit better able to survive against an intact immune system. And eventually, over time, the tumor emerges in a way that it's escaped from control by the immune system. So, the idea behind immunotherapy is to give back the power to the immune system. So we use drugs that block the abilities that cancer may have evolved to prevent themselves from being cleared away by the immune system. Now we put blocks on that ability and we reinvigorate immune cells that otherwise had lost the ability to see and attack the cancer. And the commonest and the best known and the best approved therapy targets a pathway called the PD-L1 PD-1 pathway. PD-L1 is a protein that many cancers themselves or the cells around them are triggered to upregulate and express this protein. And anyone who has been unfortunate enough to have the conversation with me in the clinic will have heard this analogy. It's a little bit like a finger coming out from the cell, and the immune system, all the immune cells, they have off switches on them. Imagine it as a light switch. Mm-hmm. The tumor has the ability, it learns the ability to press the immune system's off switch. And so the drugs that we use, and this is extending the analogy a bit too far perhaps, they either bind to the finger, so the finger can't press on that off switch anymore, or more often actually, they cover over the light switch and the finger can't get at it anymore. And so that's the idea, that's the basic tenet behind immune therapy. It's trying to switch on an immune response that has up until that point failed to get rid of the disease.
It's mind-blowing, the whole idea. I can picture it, but at the same time, the fact that we've figured that out is mind-blowing for someone who's not, into science. So it's great. To continue this conversation, I've had two other questions that came in from the community, one from Seo Jung and one from Honey. Thank you, both of you, for sending these in. I'll give you both questions and you can answer them how you see fit. Are there discussions about using immunotherapy earlier, even as a first-line treatment for certain patients? And how accessible is immunotherapy currently? And what determines whether someone is eligible?
Great questions. Yeah, there are good answers to both of those, I hope. So Barbara, you may have to remind me because I might forget the second question by the time I get to it. So in terms of using it earlier, when we first started developing immunotherapy, we, as is often the case in drug development, we were using it in people where all other means of treatment had been exhausted. So these were people who had recurrent disease. They may have had some chemotherapy for that recurrent disease. They may have had another lot of chemotherapy and it stopped working, and those patients were then offered the chance to have immunotherapy. Now, we did a trial that demonstrated that that was better than giving more chemotherapy. That was the so-called Checkmate 141 study, and it was published 10 years ago now in the New England Journal of Medicine, Changed Practice, Introduction of Immunotherapy for Patients with Recurrent Head and Neck Cancer. We did another study hot on the heels of that, where we brought the immunotherapy further forward in the patient journey. And so this was when patients first develop recurrent disease after having had surgery, radiotherapy, chemotherapy to try to cure their cancer, and then the disease came back for the first time. And we did a study where we randomized immunotherapy either on its own or in combination with chemotherapy. So the drug was pembrolizumab, and so that tends to be called pembrolizumab monotherapy or pembro chemo combo. And forgive me for saying that, but it rhymes nicely and it sort of trips off the tongue. So there were these two experimental regimens, as they're called, against what was the gold standard, which was a toxic cocktail of chemotherapy and a drug called cetuximab. And both of the immunotherapy containing arms of that trial were better than the chemotherapy and cetuximab. So that led to a change in practice, and I'll come back to that in answer to the second question in a moment. So flush with that success, obviously we asked the question, could we bring this right forward to the time that you try to cure the cancer right up front? And we've done a number of studies where we've tried to incorporate immunotherapy alongside not in the surgical sense, I'll come back to that in a moment, but in patients receiving radiation and chemotherapy trying to cure their cancer and giving them immunotherapy alongside that. And we have failed. We failed miserably in multiple trials to make that successful. But on the plus side, what we have demonstrated, and this was published recently, in fact last year, again in the New England Journal of Medicine, demonstrating that giving immunotherapy before someone has a surgical procedure can improve the chance that the disease is controlled and stays away. And we hope that that will translate in subsequent analysis to show that we increase the overall survival rate. So in that situation, the immunotherapy was given for 2 doses before the operation. Once the patient had the operation, we looked at the pathology of the material that was removed at surgery. And then we made a decision, does the patient need radiation or radiation and chemotherapy together? And we gave pembrolizumab during that treatment and then for a year after the treatment. And we've shown a significant improvement in outcomes for patients. And that again has changed global practice. And so from that point of view, we are beginning to bring immunotherapy into the frontline setting, and that's very exciting. And it's a perfect time for us to be having this conversation because earlier this week, the National Institutes for Health and Clinical Excellence approved pembrolizumab for this use in what's called perioperative treatment, in line with what was called the Keynote 689 study. So that's a huge success, and we're very enthusiastic about that. But the benefit again is modest. And so we're now already doing clinical trials where we're adding new drugs to that pembrolizumab to see can we do better. And that, of course, is the job of clinical trialists, is always to try to do better, build upon the successes they have, not rest on your laurels and go on and do other treatments. The second question...
I was just going to come in first, because this seems a really good moment to mention that our next episode will actually be having a very special guest on. Everyone in our community already knows her, but Laura, also known as Diz, who was part of that clinical trial, will be coming on to share her experience from a patient point of view of how she experienced, I'm sure, not only working with you, but also how she experienced her treatment, and now also being the poster girl of it's incredible.
She absolutely is. You know, I have endless admiration for I know her as Laura, but for Diz, I have endless admiration for her. She was so courageous in taking part in that study. She had, you know, as she'll tell you herself, she had a really difficult disease, and she went into the study. Her motivation was really about wanting to add benefit to medical science, of course, hoping for benefit for herself, I'm sure. And I'm so pleased that she's had a good outcome, and she shows enormous courage. She was interviewed, of course, live on the BBC last year, and I don't want to steal her thunder for next time, but she is just a super person and amazing outcome and a great ambassador for this approach.
Absolutely, and we're obviously delighted to have her as a trustee with the Young Tongues as well, so super engaged with us. That's amazing. So we'll go back to the second question, which was accessibility to immunotherapy currently and determined whether someone is eligible. And I just want to point out that we have a bit of a global audience, so for someone listening in the US or in Australia, this might be slightly different in terms of accessibility.
So, exactly. So I'll try to point that out as we go. So in the recurrent metastatic setting, when the disease has come back again, the Keynote 048 study, broadly speaking, has been approved based upon a protein expressed within the tumor. And I've already mentioned this protein. It's the finger, the PDL1 protein that presses on the light switch. So the level of PDL1 in the tumor not just on the tumor cells, but in the other cells around the tumor cells, that determines eligibility across the globe, actually. Now, it varies ever so slightly, but for single agent pembrolizumab, which means that you can treat people without having to give them any chemotherapy at all, and that can be a really good treatment for people with recurrent disease. Um, Broadly speaking, you need to have a positive score greater than or equal to 1, and that's about 85% of the patient population who have that recurrent metastatic disease. Now, in some places, including Japan, they allow the treatment even without measuring the PD-L1 level. For patients to receive chemotherapy and pembrolizumab treatment, most of the places in the world also require PD-L1 to be positive. But it's important to note that in America, that's not the case, in the US, and in Japan also it's not the case, and in some other places around the world it's not necessary. But in Europe, the tumor needs to be PD-L1 positive. Now here's the rub. Within the United Kingdom, the Scottish Health Authorities, the SMA, has approved pembrolizumab for treatment north of the border in combination with chemotherapy. But in England, Wales, and Northern Ireland, it is not approved by NICE and it's not funded by NICE and it is denied to patients. So
Wow.
under those circumstances, Barbara, we always try to have a clinical trial where if someone comes in through the door and we see that they really would benefit from chemotherapy to shrink the cancer and then the pembro to try to activate the immune system, we try to have a clinical trial available for those individuals. It's not always possible, but we try. And we have a trial at the moment that is running that looks really like a very promising design. And the very minimum someone gets is the chemotherapy and the pembrolizumab. Now for the perioperative treatment, so this new indication just approved earlier this week, which will become active in the coming months, again, patients need to have a PD-L1 score of greater than or equal to 1, but that for newly diagnosed cancers, including oral cavity and tongue cancers, is likely to be in more than 90% of cases. So you're unlucky if the tumor, well, you're unlucky to have a tumor, of course, but if the tumor is PD-L1 negative, you're doubly unlucky. Most patients will be positive.
Yes, so I'm going to go slightly off script, and I hope you don't mind me putting in this question, because it's a question that came in a patient discussion that we had concerning a potential clinical trial that we were going to contribute to. One of the key aspects or feedbacks that we got from patients that their biggest concern about immunotherapy being available as a first line was the impact on delays. And it was specifically from a UK standpoint, patients were most nervous about making that decision to have the immunotherapy first because they are worried, will there be delays in getting the immunotherapy, but also will it delay the tumour removal, the surgery? And I think as patients, we are very much, we just want the thing out. And you could understand why.
Yep.
And we had the previous explanation of how immunotherapy works. How would you speak to patients who have that type of concern?
Yeah, and I have done, Barbara, as you can imagine, in the clinic, and it's a very human position to take, isn't it? And I can, I don't have personal experience, but I can identify because I've spoken to many, many hundreds of patients with newly diagnosed cancers, and that instinct, just get this thing out of my body, is the most natural thing in the world. I can fully understand that. So the view that I take, and of course it's easy for me to take this because I might not necessarily be sitting on the other side of the table or the other side of the conversation, but the presence of the tumor is potentially an opportunity for the patient. Now that sounds like a strange thing to say, but the tumor contains the information that your immune system may need to mount a lasting anti-tumor immune response against the tumor. So by that I mean that the tumor contains mutations. Those mutations make slightly different versions of normal proteins. Those little bits, the proteins are chopped up into little fragments, and those fragments are often shown on the surface of the cancer cells. And those serve as the recognition points for the immune system to attack the tumor. and those are called antigens. And those abnormal tumor antigens are the thing that the immune system learns to recognize as being a sign that that tissue, that cell shouldn't be there, and they will attack on the basis of that. Now, we've already discussed the fact that through that 3E's process, elimination, equilibrium, and then escape, the tumor has learned how to bypass the immune response through some mechanism or another. Now, by giving pre-operative immunotherapy, what we try to do is to wake up the immune system so it sees that cancer when it's still there inside the patient. And in killing some of those cancer cells, it serves as essentially a massive immune boost, almost like a vaccination event against the tumor. And then you take the tumor away, but the immune cells that saw that dying tumor while it was being attacked persist in the body. And we know from the clinical trial that the benefit that we see in the Keynote 689 trial is that it protects people against systemic metastatic disease, the disease coming back in the lungs, the lymph nodes, the liver, the bones, anywhere else in the body. So essentially what we've got is clear evidence that we're vaccinating the patient against their cancer. The problem with going straight to surgery, which again is a perfectly understandable thing to want to do, is that you miss that window of opportunity to immunize the patient against their cancer. And then the counterbalance, which my surgical colleagues worry about, which I worry about, and which the patients will undoubtedly worry about, is what if the immune therapy doesn't immunize against my cancer? And I've just left the cancer there for another 6 weeks, and I've given it a head start against the surgical procedure that I'm about to have. And that's the conundrum that we face, and that's what we're trying to understand: who really does benefit, who doesn't benefit. But in the big clinical trial that we did in many, many hundreds of patients, overall, we saw that the balance of effect was in terms of benefit for the patients who received pembrolizumab. So I'd be very happy to discuss this with any patients who have that conundrum and they're facing that discussion. But overall, we think that the benefit is likely to outweigh the risk, and that then translates to an outcome benefit for patients.
Thank you. Thank you very much for that. I go to a next question from our community, from Sarah Jane. Actually, Sarah Jane is a clinical colleague of yours who also had tongue cancer. So she's in a very specific and a very unique situation, but you'll probably notice by the way she posed her questions. So how do you think we'll be treating tongue cancer in 10 years time, and how close are we to more personalised or molecular guided treatment pathways within the NHS stroke globally?
Okay, that's a great question. So the next wave of clinical trials are going to be adding new drug therapies alongside the pembrolizumab. And so there are not just pembrolizumab, other immune therapies as this so-called perioperative approach. So there are really very exciting new drugs that are coming through the pipeline in development in relapsed metastatic disease. So they're recapitulating what we've done really with immunotherapy. We start treating patients who have no other opportunities, then we go a little bit earlier in the journey, and then we bring it into the curative setting. But we're already open with a clinical trial with a novel drug, and I'll give you an example. And by no means is this the only example that exists, but I presented some data actually in Berlin at the ESMO meeting in October last year with a new drug which is approved in lung cancer but is pretty much brand new in head and neck cancer, called amivantamab. It's a slightly difficult name. Now that showed really very profound activity in patients who had relapsed metastatic disease and who had already received immunotherapy and already received chemotherapy for that relapsed disease. And we saw a response rate of 45% in that group of patients. And that's unprecedentedly high in that recurrent setting. And so we've taken the decision, and we, with the sponsor of the study, so the company that leads on the development of this drug, to bring this right the way forwards and to do a small experiment where we're offering only 20 people globally the opportunity to receive pembrolizumab plus this drug amivantamab. And we're asking the question, can we improve the response of the disease in terms of being able to shrink the disease and improve the immunization event? So to come to Sarah Jane's question, what are we going to be able to do? Well, I think we're going to have a range of different drug combinations that we can use. So for some people, it might be just the immunotherapy is all you need. For some people, it might be immunotherapy plus chemotherapy. For others, it might be immunotherapy and a targeted drug. And in an ideal world, and maybe 10 years is too short a time horizon for this, we'll have done some profiling of their tumors. We'll have a biomarker that says, well, patient A needs this, but patient B needs something else, and we'll have a different approach. And of course, we may have some patients where we just say, look, this isn't going to work. We know that you've got the type of cancer which we can try as hard as we like, but in our current state of knowledge, immunotherapy is not a good idea for you, and instead you should go straight to surgery, for instance. So I think we will get close to a point where we've got studies that are telling us those sorts of things. My absolute dream is that we have effective treatments where we give them, and for some patients, the disease shrinks away so well that we either do a much, much smaller operation, we have to give fewer and fewer people radiation after they've had that smaller operation, we use the chemotherapy that we have to give, which is so toxic, in fewer patients again. And for some people, maybe just we'll get to the point, maybe 10 years is too soon, but in the future, where there will be people who don't need an operation on their tongue, they don't need to lose tongue tissue, they don't need to lose function, they don't need radiation, which increases that risk of second malignancies that we discussed earlier in this discussion. We don't need to add chemotherapy, which has such appalling side effects for people, affects all sorts of things longer term, including things like fertility for young people with tongue cancer. And I am very, very hopeful that we'll get to a point there. Maybe we'll, for some patients, we'll put the surgeons out of business, and we'll put me out of business, radiation oncologists out of business as well, and we'll use drug treatment alone.
Yeah.
But that's a little way away.
Yeah, well, that would be music to the ears of all our community, because
Yes.
we don't only talk about survival, as important that is, and we all want to be here, but also quality of life way beyond treatment. And
Yeah.
I'm sure you'll be just as aware of the long-term effects, which aren't really talked about enough, in our opinion anyhow, of what happens 10, 15 years after radiation, because I guess we have that prolonged lifespan, having been diagnosed quite young, with all the additional new diseases that we encounter the older we get. One of the things that I just wanted to share, in terms of my personal experience with having founded the Young Tongues, we just turned 5 recently, from setting up the Facebook group, and I reflected on this a while ago, actually, when I've started to have more proactive discussions about how we can get involved in research. And one of the things that was really hard to deal with in the early days was when we had, firstly, we were a much smaller group, so we got to know each other a lot more intimately than we do now, with there being over 1,000 of us. But when we did have someone in the community who had a recurrence, who had exhausted the traditional, shall we call them traditional treatment, there was a really clear pattern, and it was hard, because we weren't talking about years, we were talking about months, and we were talking about those months also being quite devastating in terms of the experiences individuals were having. And at one point, I remember I actually thought, is this doing more harm than good? Because these things are happening, we're sharing the stories, we're having to break bad news, and that can have also a very detrimental impact on everyone who's still here. And I was really wondering, well, does what we do as a group outweigh the grief and the sadness that we have to contend with being a community? And it's only about a year and a half, maybe 2 years ago, where things really rapidly started to change, and where patients were contacting me, breaking the bad news, it's back. But then coming back within weeks going, hey, I'm on this clinical trial, I'm on that clinical trial. And I'm really happy to say that I can think of 5 individuals on the back of my head who called me 2 years ago, and they're still here, and they're not just here but have reasonably good quality of life. Some days are better than others, and we go through different phases. But that be all my expectations of when I put down the phone thinking, oh my God, that's another person that I'm going to have to say goodbye to in 3 months' time. So all the work that you and your colleagues have been involved with, we're seeing that coming through on our side now, and I'm so glad we continued and we're still here, and we're supporting people through that. On that note, how important do you feel is input from the patient voice when shaping and prioritizing research and clinical trials?
Well, it's important on a number of levels. There's no question that when we're developing new therapeutic approaches. So, for instance, when we were beginning to think about doing the Keynote 689 study, now that was almost a heretical view that you would delay someone's surgery by the 6 weeks of the treatment, but of course there's about a 2 to 4 week period while you're doing what's called the screening, doing the scans and the blood tests and checking everything's lining up in order for the patient to take part. So you're really looking at maybe an 8 to 10 week delay in an operative procedure, and you're asking patients to trust you on that. And of course, in order to have that conversation with patients and to know that you've got a trial that's appropriate for that setting, you have to take the temperature of the water. You have to ask, what does the community think? So that's exactly what we did as part of the discussion. Was we did get some feedback from patients and their carers about whether or not this would be an appropriate thing to do. Now, that wasn't universally. It wasn't a green flag. And yes, of course, it's a brilliant idea. Lots of people were concerned, and we took those concerns into account. But of course, when we went to the regulators, because of course you can't do any clinical trial without persuading a regulator that, first of all, it's a good idea scientifically, that it is safe and sensible, is what I say to patients when I talk to the MHRA, that I'm going to check with them that it's safe and sensible to ask human beings to subject themselves to this. And we had to have some evidence that we'd spoken to groups of patients who said, well, we understand what's involved here, and we think that this is a goer, because there's no point writing a clinical trial protocol and having it approved and getting ready to do a gigantic study to prove something's really clever, and then patients run a mile from it because it's absolutely nothing they'd ever do. So that's on the first rather, it's a slightly fatuous example, but that's a very clear example that you've got to be with the community and speaking their language, and you've got to have them alongside you when you go to the regulator, either in written form or better still, someone sitting in the room with you saying, yes, we've taken, I represent an independent group of individuals and we've discussed this, and we think that this actually, it has its challenges, but this is an important potential step forwards. So that's absolutely essential for us to be able to do what we do. And of course, that's even more important, I think, when we're looking at the setting that you've discussed, I think, Barbara, of patients who are potentially dying of their disease. And it's a really tricky decision sometimes between bringing someone back and forth and using a lot of their remaining lifespan traveling to and from hospital, having unpleasant tests, receiving treatments that do have side effects and which may make them more uncomfortable than they already are, may have negative impact on their quality of life, may not improve their quantity of life, or in some situations may shorten their quantity of life. And that's a really difficult thing to calculate. And again, without taking the temperature and understanding from patient groups what's the motivation here, you really can't make a proper plan for that. But ultimately, people are different. I mean, human beings are wonderfully different from one another. And sometimes you'll approach a patient and I use the word pitch. It's not like I'm sort of trying to pitch a sales, but sometimes it feels a little bit like that. You're saying, I've got this, are you interested? and sometimes they'll run a mile. They'll just say, "No, you've got to be joking. I've had 3 lots of treatment already. None of them worked. I'm pretty miserable with this disease, but I've got things sort of under control. I know I've got a short few months left to live, and I'm going to spend them all with my family as much as I can, or I'm going to do something else." And then there are other people who just want every single thing, to know that they've done every single thing. And then there are those amazing human beings who say, "Look, I don't think this is going to work for me, but you might find something out from this." And they are truly altruistic in their desire to help the community. And you need to understand what the motivations are. And the patient voice is the only way we can get that authentic information.
Thank you. Kevin, thank you so much. It's been an absolute delight to have you on Young Tongues, on our podcast. Thank you so much for sharing all your insights with us. Really appreciate having you with us as well. Thank you so much.
Well, it's been a great pleasure, and just if I may say a final few words is I remember that I think you and I met one another after a carol concert for the first time, or it was
Yes.
something like that, a number of years ago. And I think Diz was there, and she'd just given one of the readings, and I was just really very, very excited and impressed that there was a grouping such as this that was representing such an important group of patients, a small, thankfully, a relatively small group, but growing sadly, group of patients. And so I just commend you for what you're doing. I think it's wonderful. And Absolutely, I've been delighted to come and talk to you, and always happy to come back if you've got a spare slot at some point in a few years' time, and I'll tell you what else has changed. But well done for what you're doing, and to all of your listeners, I wish you all the very best in whatever phase you find yourself as a patient or as a carer, whichever part of the journey you're on. I wish you all the very best.
Thank you, Kevin.